In the final days of October, airplanes carrying top March of Dimes leaders, including CEO Cindy Rahman and Chief Scientific Advisor Dr. Emery Selly, descended on Texas. Once on the ground, they drove to the coastal city of Galveston and then to Dallas, preparing for launch. But there was no rocket, countdown, or blast off. Instead, the executives were after a giant leap for pregnancy outcomes, the end of preventable preterm birth, and Texas held the key. With its large, diverse patient populations, world class research universities, and high volume delivery hospitals, the state had the resources and expertise to tackle the complexities of preterm birth. So on October 29th and 30th, March of Dimes opened its newest research hub there, the Texas Collaborative Prematurity Research Center, a partnership between March of Dimes and UT Southwestern Medical Center in Dallas and the University of Texas Medical Branch in Galveston. Led jointly by UT Southwestern's Dr. Catherine Spong and UTMB's Dr. Ramkumar Menon, the collaborative will pursue distinct yet complementary research tracks. At UT Southwestern, Dr. Catherine Spong has access to diverse patient populations and is examining how nutrition, socioeconomic factors, the placenta, and bacterial vaginosis affect pregnancy outcomes. At UTMB, principal investigator Dr. Ramkumar Menon is using pregnancy on a chip technology to study the biology of preterm birth and to test drugs that might reverse it. I've interviewed both scientists separately, with each conversation the subject of a standalone episode available now. This is the episode starring Dr. Spong from UT Southwestern. Here it is. Dr. Catherine Spong is a professor and chair of the Department of Obstetrics and Gynecology at UT Southwestern Medical Center in Dallas. She's also one of two principal investigators at the March of Dimes Texas Collaborative Prematurity Research Center. Dr. Spong, welcome to the show.
Thank you so much. Delighted to be here.
Congratulations on the PRC.
Thank you. We're very excited.
The PRC is new to you, and this PRC is new, and your role within it is new, but you have been a collaborator with March of Dimes for a long time, for many decades, I think. In fact, one of our colleagues in the research department, Lorraine Gore, shared a really heartwarming story about her babysitting your newborn during a meeting that you attended at March of Dimes, I think in 2012.
That was 2012.
Maybe not that year, but around there.
So 2013, my last child was born. So maybe it was in 2013. It could have been in 2012, and then the kid would have been, walking and talking.
Yeah, exactly. So it was probably 2013. Amazing. Dr. Spong, in the field, you are a household name. You're chair of UT Southwestern's OBGYN department. You're a medical doctor taking care of high-risk pregnant women and delivering their babies. You're a prolific editor and contributor to the field's most renowned reference texts. You're a 20-plus year scientific and executive veteran of the National Institutes of Health. You are the author of more than 550 scientific papers. I'm sure that number is higher since I checked it, and it was probably a 6-month ago figure. So that's probably at 560 or maybe close to 600. You're a sought after expert for national TV and radio, and you're a wife, a sister, and a mother to 4 children. That's 4 children. And now you are one of 2 principal investigators at the new March of Dimes Texas PRC. And we're so happy for that additional title to your resume. But Dr. Spong, I truly wonder, do you have time for another job?
Absolutely. It's an honor and a pleasure to be a PI for a March of Dimes Prematurity Research Center. I remember when they were first being formed and thought about and born when I was at the National Institutes of Health, and there was lots of good, robust dialogue about what the March of Dimes wanted to focus on and what are really important areas and issues in health and disease, and was thrilled that March of Dimes focused on prematurity and preventing prematurity. And it's just an honor to get to play a role as a PI at one of the prematurity research centers. So thrilled to do this and thrilled for the institution. We've got so many scholars and people very interested in improving maternal and child health, and giving them that opportunity as well is really exciting.
That's lovely that you said that about the rest of the team. And yeah, I can't say how many times everybody within the research department has said we are so lucky to have Dr. Spong. Kathy Spong is a legend. So
Oh, it's very
we
kind.
we are so lucky. Now, you continue to have an incredible, impactful career as a physician scientist in maternal fetal health. What drew you to this field some 25 years ago? Why pregnancy? Why moms, babies, research? When you were a medical student at the University of Missouri, Kansas City, you probably did your rotation, right? And you were hooked, or was there a mentor that brought you in? What was it?
Yeah, so I had a number of reasons for coming into OBGYN, although I will say that I did not make my final decision until late. I will say it was probably formed much earlier. When I was
Hmm.
a first year medical student, I was in a laboratory, I was in my biochemistry class, and we had a guest lecturer. Maybe the professor was ill, and he came in and was talking, and he said at the end of the class, he said, I'm new to UMKC. My name is Mahmoud Ahmed. I have a laboratory. And if any of you are interested in doing research, I would welcome you to talk with me. And I'll admit that I was like terrified that everyone was going to rush to the front of the room and be like, me, pick me. And interestingly, I think I might have been the only person who walked up to the front of the room and said, hey, I would love to hear more about it. And Mahmoud was studying the placenta. So I actually worked in his lab for 5 years and studied the placenta and really got involved in a lot of research in OBGYN. I was doing OBGYN research as a second year out of six. This was one of those 6-year medical programs out of high school. So very interesting program to be in. And really learned a lot about OBGYN through those research years. And then as I was making my decisions about what did I want to do, OBGYN has some wonderful aspects to it. It, in my mind, is the only field that has pure joy. You remember who delivered your baby. You may or may not remember who took your appendix out or who fixed your diabetes, but it's a really important aspect of your life, giving birth to your child. There's difficulties as well, and those can also be really important when you're caring for someone and their baby may not survive. What you can do to help with that is also equally important. Um, I've I'm the younger of two. My sister is older than me, and she is the smart one. And so I used to do research because you could, come up with things, and all you had to do was be persistent. And so I did a lot of research in high school and a lot of research in medical school because it was something that I knew that I could do and do well. And one thing I love about OBGYN is there's so little evidence that I knew I'd never run out of things to do. I really enjoy answering questions, and there's so much opportunity to do that. My high school had a program where you could do a year of a research project, a science project, and I struggled initially to be able to get the cells to culture, et cetera, and trying to really make this project work. And one of my friends, as I was talking about it in our AP Chem class, she went home and talked to her dad about it, and her dad hooked me up with someone down at Wash U, and so I started going down to Wash U, and the project really took off, and it was really super fun. It was super fun. I won the science fair that year in St. Louis, and really set me up for a career.
Yeah, and the rest was history. So, what would you? So clearly, you liking to ask questions and find answers. Your curiosity is a key characteristic of yours that probably has played a role in your success. What else would you say has helped you succeed? Because I know that there are must be plenty of young scientists listening to this now saying, "I want to be like Kathy Spong, 4 kids, an incredible career, doing something she loves, advancing the field." What, how did you get here?
I would say it's the people around you, right? So no one can do it alone. And so having a cohort and a cadre of people around you, both above you helping you, as well as just around you helping you, and ensuring that you have the ability to get done what you need to get done. So any success that I've had is because of the people who've been around me.
A good leader always says that. Let's talk about UT Southwestern, Kathy. When you left the NIH, because you were actually at the NIH for 23 years
23
before you
years.
went to UT Southwestern in 2018. So before you left, or when you left the NIH, to UT Southwestern, you were really going from one powerhouse to another one. UT Southwestern is a major research hub in the pregnancy, birth, and as our chief scientific advisor, Dr. Emery Selly, tells me, the infertility fields as well. He says all the major players, the textbooks, everything is from UT Southwestern. Its faculty are some of the field's best. Its studies are some of the most cited and adopted. I'm sure that includes yours. Its OBGYN residency program is actually the country's biggest. So you're producing probably the most talent of anybody else in the country. You've previously said the university has, quote, a passion for creating the evidence for obstetric practice. So few words in that sentence, but such a huge statement to make. Very foundational, this university that you call home. So talk to me a little bit about the legacy and the future of OBGYN at Southwestern, and where we fit in there, the medical progress that maybe we can do together as a partnership with the PRC.
Absolutely. So as I left the National Institutes of Health and was looking for a new opportunity, UT Southwestern was kind of the best of all potential places to be, right? For someone in obstetrics and gynecology, who loves clinical medicine, who loves education, who loves research, there's no better place to be than UT Southwestern. Clinically, we deliver on this campus about 14,000 babies a year. That is 2 kindergarten classes a day. That is 30 to 50 babies a day. That's something that happens 1% of the time. You see it every 3 days. So you have a infrastructure really to be able to create evidence for practice. We have a large residency program, 18 residents a year, 72 in the program, and that allows us really to train the next generation. 1 out of every 70 OBGYNs trains either as a resident or a fellow or as a medical student with us. And then in research, UT Southwestern is really known for research, especially basic research with their Nobel laureates and all the people in the national academies. The textbook Williams Obstetrics and Williams Gynecology is here at UT Southwestern. And as you write each chapter in that textbook and you write a sentence and you say, well, what is the evidence behind it? We have the opportunity here to create that evidence, right? And it really highlights for us what is needed to be studied and what is the next study for us to do now. So we're able to leverage this population to be able to evaluate the impact of different interventions. As an example, we were looking at postpartum pain control in women who had a cesarean delivery. And Dr. Elaine Duryea led a team who looked at how can we reduce the use of patient-controlled anesthesia and
Okay.
instead move to a more enhanced recovery after surgery model. And over a series of 3 steps, introducing this idea of giving scheduled non-opioid pain control and really looking at what pain control patients need, was able to reduce by 90,000 pills the amount of opioids going into Dallas. So simple interventions to reduce pain, to address pain control after cesarean delivery and to reduce the dependence on opioids really has a transformational impact on the community and on the public health in Dallas.
Well, I'd like to ask a related question, Kathy, before we move on, which is a question about cesareans. But I wonder if there's any work that you're doing when it comes to cesareans and trying to lower the incidence of cesareans. Obviously, this is a problem across the country for women, and especially women with higher risk, African-American populations, Hispanic populations, which you have a lot of at Texas. So I wonder if you have any thoughts on cesareans and kind of where we're going with research on how to reduce those.
Right. So this has been a passion of mine since throughout my career, and certainly at the NIH, we had a number of conferences on how to prevent cesareans. The safest delivery for mom and baby is an uncomplicated vaginal delivery. The difficulty is you don't always know who's going to have an uncomplicated vaginal delivery.
Sometimes a low risk person will have a difficult delivery, right?
Absolutely.
Yeah.
And it's, you can't triage and say, okay, this person is completely low risk, everything is going to be fine. The primary driver of cesarean delivery is a prior cesarean delivery. And so trying to reduce that first cesarean delivery has been something that we've focused on a lot. There have been conferences that we had at the NIH on this, on how do you prevent that first cesarean delivery? What are different steps? And there's lots of different models on how to do that, and people have implemented different things to try to address that. I would say our primary cesarean delivery rate at UT Southwestern is quite good, but you still have the aftermath of the people who've had a prior cesarean delivery, and then it may be the safest delivery for them in a subsequent pregnancy is a repeat cesarean.
We started this by when you said we would deliver a lot of babies at UT Southwestern, and you mentioned 2 kindergarten classes a day. That's 30 to 50 babies. I love the metaphor. First of all, it really helps you understand how many babies you're delivering, and because of this volume, rare conditions in the fetus or the newborn and the mother are seen quite often, actually, right? Like almost daily exposure to rare 1% of the time conditions. So I think 1% of the time conditions you see every 3 days. Tell me why this is important. What are some of these adverse conditions you're seeing, and why is it beneficial to see them so often?
Um, I don't think any of us wants to see these rare conditions, and we don't
No.
want these rare things to happen.
Yeah.
I think for the trainees, it gives them a good exposure so that instead of just reading about it in a textbook or hearing about it, they're able to actually take care of it. And then when they go out into practice, they feel more comfortable because they have had such a breadth of exposure to different conditions. I think it's also helpful in that you are potentially able to study them, to be able to look at, what are the impacts of this more rare condition on pregnancy itself, on the mom and or the baby. A good example is we've done some recent work looking at different cancers in pregnancy,
Hmm.
because there are times when cancer occurs in a pregnant woman, and you're going to treat her because that's the right thing to do. There's not a lot of data out there, and we can then collect and pull together the information that we have to help guide others when they experience caring for a woman with a similar condition.
Yeah, absolutely. So, Dr. Spong, I mentioned all the things you're very good at the beginning of this episode. One thing I didn't mention is another thing you're very good at, and that is conducting clinical trials. In fact, you lead the NICHD's maternal fetal medicine units network. This is a group focused on well-designed clinical trials in obstetrics because we need them, ethically and well-designed clinical trials, and more of them to learn more. And at Southwestern, we've been talking about it, you have at your fingertips a large underrepresented patient population, so women that are at higher risk of adverse outcomes, and years of experience running clinical trials. That's a lot of scientific potential that you have there.
Absolutely. So I was fortunate to lead the MFMU network for a little over a decade, probably about 12 years in the 2000s. And, it was a wonderful way for me to really participate with a diverse group of PIs across the country to create that evidence for practice, to study the things that were pressing, and to really be able to address and create evidence that we use to this day on how we care for pregnant women. UT Southwestern, with the volume that we have, has afforded us a similar opportunity. Some other examples that we have been able to take on are looking at different labor induction agents. Induction of labor can be done in many different ways, and they're all appropriate, different medications, different routes of medications. And so we're able to study those here at UT Southwestern, where we can compare 2 different medications and evaluate which one is more likely to have, which method is more likely to result in a vaginal delivery. Are there any risks associated with infections with different methods? Another really fun study that we did a couple of years ago was we had recognized that the definition of anemia was from the 1970s. There were 3 Scandinavian studies. And we felt that maybe that wasn't appropriate for this day and age. We should study what is the definition of anemia. So we used 1,000 women, both at Parkland as well as at Clements University Hospital, so 2 distinct populations, and women who had no diabetes, who were not overweight, et cetera, and came up with what is the definition of anemia, by the cutoffs. And in doing so, created a standard in the United States for what the definition of anemia is. We recognize that a lot of women were anemic at the time of delivery. And although we routinely recognize and recommend women to take iron during pregnancy, we thought, well, maybe there's an opportunity here. So we did a study where instead of telling people to take iron, we actually handed them a vial of iron at their prenatal visits. And when they were offered, refills as they finished their bottles of iron. And we were able to show that this simple public health intervention of actually handing out iron reduced anemia at the time of delivery and reduced symptomatic postpartum blood transfusions. So simple interventions that can have a huge impact to improve the health and outcome for the pregnancy, for the mom and the baby.
Yeah, that's incredible. And it makes total sense. You remove that step of the woman having to go and get the pills herself or the prenatals herself. You're saying, here you go. And you can trust
Exactly.
me. Take this. So that's fantastic. Well, speaking of iron, I want to talk a little bit about nutrition. So this is a key focus of the PRC. It's nutrition. And your first study at the PRC, the focus that it's a big study, and this is a study that you're going to undertake to examine how socioeconomic related nutritional deficiencies. So I just want to say, I think that means nutritional deficiencies as a result of either not having enough money or not having transportation or not having the information you need, the resources. Oftentimes, that's what that means. So the mix between socioeconomic related nutritional deficiencies, abnormal placental metabolism, and bacterial vaginosis. So that's those three factors. How do they affect preterm birth and other adverse pregnancy outcomes? I know there's a community component here, and a lot of your work at UT Southwestern involves this community approach. So tell me about this study, Dr. Spong, and kind of where this community comes in.
Absolutely. I think one of the difficulties that we have in pregnancy is how can you determine a nutritional status of a pregnant woman? It's very difficult to the way that you determine nutritional status in a non-pregnant person doesn't translate to the pregnant person, and sometimes there is a concern that you may be overweight, but you may not be nutritionally sufficient. I'm really interested in understanding how do we optimize nutrition in pregnancy, and how do we identify patients who do not have adequate nutrition. One of the big concerns that I have is a patient who ends up having a cesarean delivery. If they are not nutritionally sound, they're more likely to have a wound infection, right? And that's just a huge complication for a new mom to have a wound infection. And so if we can prevent that, it would be wonderful. But to do that, we need these tools. We have been, over the last several years, working a lot with the community to understand, what kind of studies would be of interest, and what are outcomes that are of interest. And we have a large PCORI grant looking at postpartum health. And as part of that, we have feedback with patients and providers to understand, what are topics that are important to them and what are interventions that are acceptable to them, because both of those are really important. In the Parkland system, there are 10 outlying clinics located where patients live, so they have access for prenatal care. In fact, 97% of our patients access prenatal care, which is a remarkable fact for our patients, and a way that we can improve our outcomes. And one of those clinics, the Garland Clinic, is located in an area that has some higher risks of preterm birth. And so we're really going to target the Garland Clinic to start with, to recruit these patients, to be able to collect information on their nutritional status, to collect information on, what are they eating, what do they have access to, as well as looking at their nutritional status, both macro and micro nutrients, and really trying to understand how can we characterize nutritional sufficiency in pregnancy.
So abnormal placental metabolism. Tell me about how that may impact nutritional status and adverse outcomes as well, pregnancy outcomes, and then also obviously bacterial vaginosis. We know that there's bad bacterial players there that could be a driver of preterm birth on its own.
Yeah, so we're very interested in understanding and studying the placenta. That's been a long passion of mine as well. And Dr. Ashley Salmonson is with us in both the Department of OBGYN as well as as a member of the Green Center. And she's really interested in metabolism and is working very, very closely with a number of my um, uh, faculty members to look at the metabolism of the placenta and to understand how that changes over time and how different disease conditions change that over time. She has some really neat organoids that she's using for some of this work and is really going to be incredibly insightful for us to understand because if you don't have normal placental development, you're not likely to have a normal pregnancy outcome. So really understanding what drives placental metabolism, which is something that's woefully understudied, is a really exciting aspect of this project. And then Dr. Mala Mahendru and Dr. Jane Fumina are working on the cervix and the microbiome and trying to understand that role in preterm birth as well.
And this is the perfect storm here, right? You're looking at all those things together. How potentially poor nutrition.
We'll be collecting samples on all of these things across a
Yes.
longitudinal cohort of women, and we'll be able to really link things across time. And the potential is really exciting because we can link them all together back to that same patient and her outcomes and understanding all of these different aspects.
Yeah. Is it common, do you think, for all these things to be happening in one patient at the same time during pregnancy? Because it seems like there's a lot of bad players there potentially. Poor nutrition, poor placental development, bacterial vaginosis. It seems like that patient's really unlucky. But is that actually quite common for that probably to be maybe happening?
So, I mean, I think pregnant women, a lot of things are going on all the time,
Yeah,
right?
and they change.
And they change over time. And I think that's one of the key things about the placenta is that we have not been able to really characterize the placenta well across pregnancy because it's just inaccessible, right? I will say that bacterial vaginosis, although it is considered bad, actually the MFM network many years ago did a study looking at asymptomatic bacterial vaginosis, where women who didn't know that they had it were screened at 16 to 18 weeks, and they were then randomized to a treatment or a placebo. And that study actually was stopped early because if you treated it, you actually had worse outcomes.
Oh my gosh.
And it was probably the microbiome that we didn't understand at that time, that whatever grew back when you got rid of, there were two different parallel studies, bacterial vaginosis and Trichomonas vaginalis, but when you eradicated that asymptomatic infection, the patient was not symptomatic, you actually had worse outcomes because whatever grew back was worse than the asymptomatic BV or TB.
Okay, so as part of the focus on nutrition, we have been talking about micronutrients a little bit during the interview, and you'll also be trying to define micronutrient requirements in pregnancy.
Yes.
I know from interviewing Dr. Kimberly O'Brien, she was our 2025 winner of Agnes Higgins Award in Maternal Fetal Nutrition, that this is really not easy, is defining micronutrient requirements because of how, to use the word you used earlier, because of how they're metabolized. It's really difficult. She actually uses tracing of the minerals in the body to see how much the fetus uses, how much the placenta uses, how much the mother uses, and how much is absorbed at all, because iron is a tough one. And she's basically, she hasn't nailed this yet, but what she's very comfortable saying is the existing intake recommendations for iron are probably too low for pregnant women. And you also found this with your anemia research that you told us about earlier. So I'm guessing that's probably pretty common with other micronutrients too. What micronutrients will you be focusing on as part of the nutrition work?
Yeah, so we're very interested in understanding across the spectrum of micronutrients. Of course, vitamin B6 and DHA and choline, but I think it's key and also to understand that as pregnancy changes, right, your GI transit time decreases, your renal function changes, your liver function changes, and so what's appropriate early in pregnancy may be not appropriate later in pregnancy, and really it's very complicated. And so trying to understand what is needed across it may not be standardized across time, right? And so this is going to be really tricky. We're gonna start, and we're gonna see what we find and kind of go from there.
Awesome. Perfect. So we talked about the placenta a little bit. Placental metabolism is very important for proper placental growth and development, which is very important for birth weight and good pregnancy outcomes. So this is one of your favorite research subjects. Like you said, you've been hooked on it for a long time. I understand that the placenta is related to stillbirth, and I've seen that you're also interested in stillbirth and have done research on stillbirth. Can we talk a little bit about the relationship between the two, between placenta and stillbirth, and what's happening there?
Yeah, so you need a normal placental development to have a healthy pregnancy outcome. And the question is, when does it go awry? And clearly it goes awry in things like preeclampsia or fetal growth restriction. And how do we identify what is normal placental growth, placental metabolism, oxygenation across pregnancy without intervening and going invasive, right? And then if we can understand what is normal versus what is abnormal, can we then identify something that potentially could intervene? So we actually have a number of studies ongoing with Diane Twickler and Chris Herrera and Gwen Doe using MRI in pregnancy and looking at
Which is safe, right?
which is safe in pregnancy, absolutely, and looking both in conditions of chronic hypertension and fetal growth restriction, as well as in conditions associated with placenta accreta spectrum, to try to understand how does that placenta change over time, and then what potentially could we do to make that any abnormal change, to prevent that abnormal change. So lots of different ways to look at the placenta, and I think that there's some, hopefully we'll make some novel advances with that.
And obviously, we're not sure yet, but what are potentially some of the things that you could do to reverse or stop that adverse placental development, like you mentioned?
That's a great question. I think it's really going to depend on what we find as, what are the major changes to see to be able to identify what would those interventions be. But could it be an antioxidant? Could it be, something like that? All things are on the table.
Yeah. Now, you hold several patents for neuroprotective agents. That is a cool term. And these neuroprotective agents help prevent fetal injury. Tell me, what is fetal injury and what are neuroprotective agents and how does one help the other?
Wow, you're taking me back. So this was work that I did in my lab at the NIH for a little over a decade. And I started out looking at vasoactive intestinal peptide, which is really crucial for fetal growth and development and placental development, and came down to the laboratory I was working in had derived peptides from VIP that actually had neuroprotective properties. And so if you block VIP, you get fetal death and you get other complications. And I studied two different conditions. I studied fetal alcohol syndrome and Down syndrome, and I utilized these peptides in these mouse models, and were able to show that by administering these peptides, even in the face of alcohol exposure or Down syndrome, we were able to prevent the developmental delay in the Down syndrome offspring, and we're able to improve the ability for the animal to learn in the fetal alcohol syndrome model.
All right, last question for you, Dr. Spong. You and your colleagues are passionate about improving postpartum care. One of those things was what we talked about at the very beginning of the episode, right? Is a different painkiller modality, essentially, giving them something different and at different intervals. So big question, but how important is caring for the new mother, is mothering the new mother? Is postpartum care kind of an overlooked area of research and focus? And what are you bringing to that table?
Yeah, I think over the last number of years, it's been recognized that that fourth trimester,
Yes.
the after delivery time period, has significant morbidity associated with it.
In
And
fact, a
really
lot,
has,
yeah, right. A lot of
yes,
mortality happens there too. I had no
yes,
idea that,
yes.
that's actually the majority of time when the mother dies. Is not during
And it's been
childbirth.
neglected. It's been absolutely neglected, right? Because we focus so much on up to the delivery process,
Yeah,
and then
yeah.
not really focused on those, not only 6 weeks, but 6 months, that first year after life. So
Yes.
Dr. David Nelson started a program called MCAP, or Extending Maternal Care After Pregnancy, in Dallas a number of years ago now, that really showed that by providing that care in that first year after life not only improved the health for mom and baby, but improved her long-term health, where a woman who had diabetes, we were able to maintain her diabetic control. And if she didn't have care, often would come in pregnant a year later out of control with her diabetes again, which of course sets off a pregnancy on a bad foot because you want to have your diabetes well controlled. So understanding and optimizing care in that postpartum period is absolutely essential. Study that we're working on right now is really trying to figure out how can we better identify complications earlier and treat them earlier so that we can prevent patients from having to go back to the emergency room and prevent patients from having to be hospitalized. And this is looking at the major players, right? The hypertension, the infection, all of the things that really drive those initial callbacks into the hospital.
Yeah. Dr. Spong, is there anything else that you want to say that I haven't asked?
Just it's an absolute pleasure to be a part of the March of Dimes community, and we at UT Southwestern are thrilled to be a member of the PRCs and really look forward to partnering with all of the other PRCs in this journey.
Well, thank you for your time today. I can't wait to see what you do at the PRC and beyond in your other studies and trials that you're running at UT Southwestern and long after that. We're lucky to have you. Thank you.
Thank you so much.
That was Dr. Catherine Spong, who leads the March of Dimes Texas Collaborative Prematurity Research Center at UT Southwestern Medical Center in Dallas. She's one of two principal investigators at the Texas Collaborative. The other is Dr. Ramkumar Menon, who leads the work at the University of Texas Medical Branch at Galveston. You can find his episode right next to this one. Thanks for listening.